Bismillah ar-Rahman ar-Rahim. I'm really humbled in the presence of the expert cardiologist sitting here. And I must thank Dr. Bandesha for his invitation. I'm going to talk about a technique which all of you know, which was described way back in 1985, but put on the back burner. And we tried it and found it useful in our center. This is Guidewire pacing during percutaneous coronary intervention. Now we know that temporary pacing is occasionally required during PCI. It is usually accomplished by insertion of a temporary transvenous pacemaker wire or catheter into the right ventricle. However, there are certain risks and inconveniences associated with this approach, like excess site bleeding, arteriovenous fistula, infection, and then the pacing lead can perforate the right ventricle, particularly in patients with thinned out apex in inferior or circumflex infarcts, and one has seen cardiac tamponade occurring and deaths also occurring. Now this circumvents all those complications and is very, very safe indeed. We had a total of 800 patients in our center over the 7 years period, and using pacing wire, we were able to pace the heart in the LAD and its diagonal branches in over 93% of cases, left circumflex in marginal branches in 85%, and right coronary artery and its branches in 91%, which is a very high percentage indeed. And some of the skeptics and some of my colleagues have criticized this because they found that this is not that effective, and I'll tell you the reason why. This, you see that you have the guide catheter there on the left side. This was a circumflex artery which was being stented, and this patient developed bradycardia, hypotension, and we had this wire which was paced and completed the procedure very successfully. Now all you require is nothing extra. All these things you have in your cath lab. You have the PCI guide wire, and in all our patients we use BMW by Abbott Vascular. Alligator clips obviously has to be sterile. The pulse generator, which every cath lab has, a fine gauge needle, and you have needles and needles in the cath lab of 21 gauge, about 4 to 5 centimeters, tegaderm dressing, and a scalpel to scrape the coating in the proximal edge of the PCI wire. That's the PCI guide wire which we use, and you are all very familiar, and this is our workhorse wire. The alligator clips, which obviously are sterile, and you can see the clips and the ports where it has to be inserted into the temporary pacemaker. That's the pulse generator, and the pulse is usually set at about 120, depending on the patient's own heart rate, with a threshold which has to be high, 15 at least, a sensitivity of 3, and this is the needle, the tegaderm patch, and obviously the scalpel with the proximal part of the wire which is scraped, and the metal is bare. Now this is the step-by-step approach. You attach the electrode to the patient, and here you find the electrode. That's the needle which is stuck inside the subcutaneous tissue. That's your catheter where you're operating. And this is the other end of the alligator clip, which is attached to the proximal end of your BMW wire or whatever it is. And you confirm the stability of the patient by pacing, and this was paced at 125 beats per minute. And how effective is the pacing? Now, we keep the maximum pacing. Most of your temporary pacemakers have 12 or 15 volts as the maximum. Some of them also have more than this. And in certain cases, we've used more than this threshold. And the rate is set about 120 beats per minute. The complications are exceedingly low. In 2.5% of our patients, there was coronary vasospasm beyond the stent deployment, and this was easily relieved with intracoronary nitrate. And muscle twitching was seen particularly in patients where we paced, and these patients either had inferior infarct or circumflex infarct. There are certain additional uses of guide wire pacing. In some of our patients, we found that there was to and fro movement of the stent in ostial lesions, particularly in patients who had a slower heart rate, 50 or 60. The movement of the stent was quite a bit, and that made it difficult for proper stent deployment. So you increase the heart rate to 120, 130, and you reduce or minimize the movement of the stent and deploy it exactly, particularly in ostial lesions like ostial left main, ostial LAD circumflex, the diagonal and LAD bifurcation ostial lesions, and also the right coronary artery ostial lesion. And this works very effectively, although there are certain other techniques also. And we also can see roughly if a certain patient where guide wire pacing is done and it doesn't pace, that may well be an infarcted area, or it could be a recent infarct. During aortic valve implantation, which we do not do at our center, but rapid pacing is most of the times required. And occasionally in an emergency setting while doing coronary angiography, you may land up with bradycardia, asystole, or heart block. You can take the wire, right coronary catheter, put it into the left ventricle, and then make a contact of the wire with the left ventricular free wall, and there you start pacing, and the situation is averted. So those are the additional uses of guide wire pacing. Why it doesn't fail, and that is where the answer lies for the skeptics. If you are pacing in the infarcted area, you're using a low threshold, and that is the mistake which was being done by some of the persons who objected to this technique by using 3 or 4 volts. Or the PCI wire is not adequately parked distally. It has to be parked distally in one of the smaller branches. Either it's the very distal diagonal branch, or it's the septal branch in the LAD or the other arteries. And then proximal edge of the PCI wire is not scraped adequately with the scalpel, and the attachments are inadequate, where the tegaderm comes into of use. Now, if you look carefully, this was a patient who had pacing done in the left ventricle. That's the wire, that's the right coronary catheter. This patient crashed while doing the right coronary angiogram, and there the pacing started, the patient was revived, and it was safe outcome. This was another interesting case who had a total occlusion of the left anterior descending artery, and there you see the 3 wires. This is one of the wire, BMW is in the diagonal, one in the LAD, and one in the left circumflex. You'll ask me why you have, doing the LAD, why you have these 2 other wires. The reason was that this was done for guide support. Now, when we opened up the LAD, placed in a stent, initially it would not pace. But after about 5 to 10 minutes, when the perfusion in the LAD territory was there, the patient started pacing. So we tried separately the LAD, diagonal, and left circumflex. In each branch paced very nicely, although with a different threshold. The LED had a higher threshold as compared to the two other branches. This is the LED being paced. This is the diagonal which is being paced. And you see how good and nice is the pacing. And this is the circumflex which is being paced with the guide wire. This was another patient who had right coronary artery occlusion, had again compromised or was unstable, where pacing was done at the same time, and the patient had successful angioplasty done to the right coronary artery. This was another patient who had bradycardia with cardiac asystole, where the obtuse marginal artery was stented, paced, and the patient had a successful outcome. Now, this was a patient, a lady who was operated upon, and the only surviving graft was Lima to LAD. Lima was patent, but beyond the insertion, there was a tandem lesion in the LAD. Wire was crossed. We were thinking of putting in a transvenous pacing lead, but we paced it with the wire here in distal LAD and stented this with the pacing there. Probably never been described earlier on. At least I couldn't find it in the literature. This was a patient of hypertrophic obstructive cardiomyopathy. We did this last month, where septal ablation was done. The guide wire was in the LAD, and we tried, and we know that in a number of patients where you do septal ablation, you require temporary pacemaker. The LED guide wire would not pace. So my cath lab technician said, why not, sir, put the guide wire, another wire into the circumflex, and it started pacing. And the probable reason of not pacing in the LED was that in patients with hypertrophic cardiomyopathy, long-standing, they can have scarring of the left ventricle, and that may be one of the reasons why that was more of an infarcted area or scarred area, and that was not pacing, and the pacing was done on the other side. The technique in hypertrophic obstructive cardiomyopathy, cardiac pacing, not with through transvenous route, but by the wires, not been described, at least I didn't find anything in the literature. So in conclusion, my dear colleagues, coronary pacing is safe, very safe indeed, feasible method, and very feasible indeed for the treatment of bradycardias during PCIs. We've done it in 800 patients. It avoids additional venous punctures under hemodynamically unstable conditions, and there is absolutely no additional cost. You have all these things in the cath lab. Try it, and you'll find it successful if done adequately. I was just reading a report, and it has been mentioned that if you put one of the alligator clips posteriorly of the chest wall, you would have 100% pacing. And that is one thing which I'll try later on, but I'm still very skeptic about that, but that is what has been mentioned. So thank you very much once again.